Okay, so our first speaker is Dr. Joshua Zaritsky. He is the Chief of Division of Nephrology at the Nemours Alfred I. DuPont Hospital for Children. He is a graduate of Stanford School of Medicine, completed his residency in pediatrics at Denver Children's Hospital, and completed a fellowship in nephrology at Battelle Children's Hospital at UCLA. He is board certified in both pediatrics and pediatric nephrology. He has lectured and published extensively in the fields of chronic kidney disease, iron metabolism, and metabolic bone disease. He is active in several national and international pediatric nephrology research collaboratives. His special interests include acid-base and electrolyte abnormalities, acute kidney injury, dialysis, and renal transplantation. And this morning he will be talking to us about addressing the challenges of transition in pediatric CKD patients. Dr. Zaritsky.
Thank you very much, and thank you, Claudine, and the group for having me. You know, as I was putting together this talk, I had a chance to kind of reflect. I'm certainly not a transition expert, but one of the obvious questions is you could have the best pediatric hospital and right next door the best adult hospital. And honestly, I really believe in Delaware, the level of care we're able to provide is, up there on that national level. But if you can't get the patient from the pediatric hospital to the adult hospital, it doesn't matter how great your care is. There's a divide there that somehow we have to work on and consistently work on. So my disclosure is actually I am a speaker for Alexion. So the objectives today, I'll briefly fill you in on the burden of CKD in the pediatric population. Sometimes it gets kind of dwarfed by just the volume of disease in the adult population. I'll describe some of the challenges with chronic kidney disease, especially that transition to adult care, and then some special insights, in particular the idea of CKD and some of the things we've learned from our children with CKD. So, how about epidemiology? So, if you look at adult prevalence, like you mentioned, there's 20 million adults with CKD, right? In children, we're not 100% sure of the prevalence, but it's somewhere just around 100 cases per million year. So just to give you some, another set of numbers, there might be 400,000 adults in the country on hemodialysis and PD. In the States, we have about 1,000 children on dialysis. When we look at national registries, it gives an incidence of pediatric ESRD, or end-stage renal disease, CKD5D, about 15 cases per million. And fortunately, the 10-year survival rate for an adolescent onset ESRD is much better than it is for adults. It's about 80%. So that might seem like, hey, you're great, you're doing a good job, there's not a problem there. But if you look at the mortality rate within the general U.S. population for adolescents, it's a 30-fold increase, which is incredible, which is really incredible when you start to think about it. So, how about the epidemiology? Most disease is congenital in nature, and we've started using this term congenital abnormalities of the kidney and urinary tract. Recognizing that you have a problem with your urinary tract or the plumbing, a lot of times a problem with the kidney comes along with it. And we've actually been trying to work better with the urologist to make sure that the urologist doesn't wave goodbye and then that patient presents to the adult group at age 40 with a problem. And a lot of times the disease we see, although we do have adult cases, cases of sudden onset of disease where a child presents with very bad chronic kidney disease, most of it's gradual onset, and we have this kind of idea in the nephrology. It's called the Brenner hypothesis that you're given a certain amount of renal mass, and at some point, if I shave away enough renal mass, that renal mass is not going to be able to sustain you. So at birth, you might have enough renal mass to kind of get you through, but by ages 6, 7, that renal mass, especially as the body starts to grow and there's higher metabolic demands, you burn out the rest of your kidney. So a lot of the disease we see is a little older. And you'll see, especially through the transplant, in a lot of ways we are adolescent doctors for the most part, especially for chronic kidney disease, which has its benefits and has its minuses. If you have an adolescent at home, you know what I'm talking about. So this slide, I think you always have to show this slide in any good nephrology meeting. And this slide kind of brings you the picture about, well, what's it like? What is survival like on hemodialysis? And the point of this slide is basically compares cardiovascular mortality or annual mortality compared to sort of average patients out there in the community or controls in the community and patients on hemodialysis. And you'll notice it's a logarithmic scale here. So the example is if I have a 20-year-old who comes to me with chest pain and is otherwise a healthy adult, the chances that there's something bad's going to happen to them in the next day or so is almost zero. It's usually something musculoskeletal. It's usually not a problem. But if I have the same dialysis patient come to me with chest pain, I better think and I better get that patient to a provider immediately. Why is that? Because when you look at cardiovascular mortality for this group, it approaches that of an 80-year-old. So when your 80-year-old grandparent comes to you or friend comes to you and says, I have chest pain, you don't blow it off. You run them right to the hospital, right? And we have a whole protocol set. We got to get you, to the cath lab this time. You have to think that same way for a 20-year-old with end-stage renal disease. So this is the burden of disease that we're talking about. And so if you look at the life expectancy of a 30-year-old grandson on dialysis, is that as 85-year-old grandmother. That is, being on hemodialysis is like adding 50 patient years to that patient's life. And this is something that we're working on. And it's not something that it's an adult problem. We recognize it happens very early on. And I'm sure if we had the data and we were able to extend the curve, it's not like we're going to have a curve that drops off like this. It's going to be very similar. Very similar. So that's a very important concept to recognize and to recognize the burden of disease, especially with chronic kidney disease. So this, once again, and if I'm going to give a talk on transition, one of the things I have to talk about is transplant. Why? Because transplant offers essentially it's our cure for CKD5D in pediatric patients, and it's where the best data comes for transition. So this is to remind you, say, hey, what's the expected remaining lifetime in a patient with ESRD? If you're on dialysis, you have, and you're 15-year-old on ESRD, you have another sort of average 15 extra years of lifespan. If you're able to get transplanted in that same age group, you now more than double that. And that shows you the huge advantage of transplant in this age, that years of lifespan that you're able to give that patient by transplant. And that's why the system is set up, to give kidneys to younger patients. So, and I think I just emphasized that here. You can see how much more years of life we're able to give. And this is why transition, especially for these patients, plays such a critical role. And I'll show you some very interesting studies. And this is to remind you, fortunately or unfortunately, especially in the transplant group, we are adolescent medicine physicians, right? So if you look at the number of transplants performed, and this goes back to this idea of this Brenner hypothesis, or this idea of this minimal amount of renal mass, that the most time we see patients progress with CKD is when they hit those teenage years. And so most of the patients that I'm taking care of with CKD5D on dialysis, or the patients most affected by CKD, are adolescents, basically. And these are patients that in a couple of years, I'm going to have to transition over to the adult group. So when we look at survival and transplant, how long a transplant, works in teenagers, something very unusual comes up. And this happens, I'm going to show you 3 slides that kind of beat in the same point. So just stay awake for one of them at least. So for the living donor transplants by recipient age, if we look at this age group here, you'll notice that their first-year survival in blue is almost the highest. And you'll see for deceased donor, it is the highest. Why is that? We think that you're taking someone who has one problem, chronic kidney disease. They don't yet have heart problems, lung problems, diabetes, and they're adult size. So the technical aspects of doing a kidney transplant are not that complicated. They have the best 1-year survival. But if we look at 5-year survival, it's the worst. The worst compared to any other age group. And I think I emphasize that here. And we still haven't figured out this problem. Why do they do the best? And then 5 years later, they have the worst outcomes for transplants. And we see this data, the same data, right, when we do, when we adjust 1 year and 5 year graft survival for a deceased donor. And once again, we see some of the best survival in the 11 to 17 age group the first year, and then once again in red, the worst. And although we don't know the reason, exactly, non-adherence, non-compliance, whatever you want to call it, transition plays a role in this. Transition plays a role because if you add 5 years, 17, you're 22. You've transitioned. So, and then this is, again, graft outcome by age. That when you look, especially from living donors, right, patients in this yellow here, greater than 12 years, start off with the best survival. And then as you move out years from transplant, they have the worst. This should not be happening. And we're not so sure why it happens. But clearly it's a problem. And we recognize, once again, I said the patients I'm transplanting, those are the patients we're transplanting, the older patients. Okay, so, and that's just to emphasize deceased donor as well. So, like I mentioned, the data that we have for transition, especially in CKD, comes from the transplant group. Why? Because that's a very easy group to study. We follow these patients very carefully. There's not a lot of data, but the data out there is worrisome in the sense. And this is data from a Canadian Registry of Organ Transplantation. They looked at patients who had received a graft from 0 to 18 years of age and then looked at the adaptation or transition period, which was 6 months before they went to an adult-oriented clinic and then 2.5 years after, right? And when you look here, out of the 413 recipients, 20% of those that transitioned during that period experienced graft loss. So when you compared that to the younger group, 0 to 13, who had yet to go through transition, that was over 2 times the rate of graft loss. And when you look at that, just that adaptation period, once again, about a 2 times higher rate of graft failure. So something is going on, especially with this transition in this age group. And this is the Canadian registry. We're not having problems people losing insurance. You can kind of factor that out, and you figure with a healthcare system that they have there that's the place you'd want to do a transition. Yet even with that system, they still have a twofold rate of graft loss. And why is that happening? I don't necessarily have an answer. But this paper, this Samuel paper that looked here, basically the conclusion here was that the period of adaptation to adult-oriented care is associated with a very high risk of graft failure for pediatric renal transplant recipients. So I want that to ring in your head. And then I also want you to look at that when you look at data for transitioning teenagers in general. And this is a great quote I found here, that emerging young adults often have the lowest perception of risk and the least access to care. And I always, when I'm explaining to a parent of a teenager, I have to remind them that, teenagers think differently than adults. The wiring is not complete yet. They don't have an awareness of the risk of what could happen tomorrow if they don't do A, B, and C. They don't think like adults. They just don't think like adults. And so if you look at this group of emerging young adults, they have the highest rate of motor vehicle injury, death, homicide, mental illness, sexually transmitted infections, and substance abuse. And they have the lowest rates of health insurance. So they're at a perfect, this kind of idea that we have a teenager or an adolescent with CKD, and they're still teenagers, right? We haven't taken away that part of them. So once again, we have this perfect storm or intersection of, the teenage mindset, what's going through that there, and then we add chronic kidney disease to the picture. And it's no surprise that this area, that the teenage period of time, trying to treat a teenager and then transition them to adults, is an extremely difficult time for everybody involved. Okay, hopefully I've made that point. So one other thing we have to worry about in the States is medical, insurance coverage. Now things have changed a little bit with, the ACA, Obamacare, with this idea that patients can stay on their adult insurance up to age 25. But if you look, this was a study looking at 1,000 Medicare primary pediatric kidney transplant recipients from a large period of time. When they looked at these patients, about 50% of them lost Medicare coverage during that time period. Those that lost coverage, right, they had once again this twofold number of graft loss than those who retain eligibility for Medicare, right? And if you look at the failure rates, the fourth year after cessation, it was almost double that than if you had coverage. And another way of looking at it is look at the duration of graft function, right? Right? You're losing a significant number of years just because your insurance changed or you're no longer Medicare available. So we have another kind of intersection, right? We have the teenage, we have CKD, and now we're going to throw onto that, access to insurance. So if that's not enough problems that this age group has to deal with. So moving on, and this just shows you the projected graft survival from this one paper that, observed survival with coverage, if you could actually, look at that study out time compared to without, you can see, sure, we're at this age, we're looking 3 years later, but if you look at projections, that's when it really makes a difference. That if we could somehow get these patients through this transition period with coverage, they're going to do a lot better. It's a sort of a no-brainer. So I'm not going to spend a lot of different time on transition models. That could be a lecture in itself. I kind of feel my job up here is to kind of make everybody aware of the problem and how much research needs to happen in this particular area. We need to get better. I will tell you that the most common model, and the model that we kind of use, is this idea of this direct transition. That is, I take a pediatric patient, I call up Dr. Preyas here, I say, hey, this patient is coming to see you. And if it's a good day, I kind of email him my last note, and I say, hey, this is what's going to happen. And luckily, we have a relationship with Nephrology Associates that I feel that I have a good connection, at least in Delaware. I don't necessarily have that connection in Pennsylvania, but that's sort of the model. And in some ways, it's it's the worst model. It's like, okay, you're grown up, see you later. And I'll show you why that's a problem. There's a lot of other different models, this idea of a sequential transition, and it's an intermediate step model that you actually identify and you have a transition clinic out there that takes resources, it takes docs who want to take care of the problem, but where you gradually transition that. So you could either consider it an adolescent clinic, a young adult clinic, where there's a more gradual stepwise. Some models actually have both the pediatric and adult doctor there at the same clinic in with the patient and eventually transition them over to adults.